methanol poisoning, Cushing's syndrome, diarrhea, and severe anemia. The answer selected here is methanol poisoning. Do you think it's correct or it's wrong? And if it's right, what do the other choices cause? I guess you can also chat. You can also put it in the chat box. What type of electrolyte imbalance does narcotic overdose cause? And also, what type of electrolyte imbalance is caused by diarrhea, or does diarrhea cause? You guys don't be shy. Just put your answers in the chat box so that we can also move faster. Okay, thanks to everyone who said something. Sean said methanol poisoning is correct. Narcotic overdose causes respiratory acidosis. And Nathan said diarrhea causes metabolic acidosis. I agree with all that. But so now we have to ask ourselves, why is methanol poisoning correct and not diarrhea? The question asks which causes high anion gap. And for high anion gap, there's an acronym. I hope you'll be able to see. Yeah. I hope you can see my slides still. This is the acronym for the causes of a high anion gap metabolic acidosis. It's CAT, MAD piles. I'll send the slides so that you can look into it more keenly. But for now, we can see M here in MAD piles stands for methanol. So methanol poisoning is correct. Next we have number 9. Insulin deficiency is associated with reduced gluconeogenesis, reduced proteolysis, reduced lipolysis, hypoglycemia, or increased ketogenesis. So bearing in mind that insulin deficiency causes a decreased uptake in glucose inside the cells, what sequence of events would be expected to happen? You can think about if glucose isn't being taken into the cells, then how will the cells obtain their energy? So what else in place of glucose will be released? So an insulin deficiency causes a decreased glucose uptake in cells, and in turn, fatty acids are released. This is the process called lipolysis. And the fatty acids are transported to the liver. They're converted to acetyl-CoA, and acetyl-CoA is a precursor in ketogenesis, the synthesis of ketone bodies from fatty acids. So the answer is E. The next question we have is on cardiac biomarkers. Number in A 37-year-old patient presented 6 hours after the onset of suspected myocardial infarction. The most appropriate cardiac marker to request at this time is CKMB, myoglobin, aspartate transaminase, total CK, troponin I. Okay, so my first question is, do you think the answer selected here is right? And if yes, support your answer. If not, also support your answer. CKMB is detected in 3 to 12 hours. So is the answer right or is the answer wrong? It's true, it's detected in 3 to 12 hours. Okay, this is taking a lot of time. So I have a graph here that shows the time after onset. So you know the degree of elevation against the time after onset of acute myocardial infarction. So at around 6 hours, you can see the most elevated is myoglobin, followed by troponin I, then troponin T, and finally CKMB. So while yes, CKMB is starts rising in 3 to 12 hours, it's not the most accurate to take from this because you can see it's not yet reached its peak, A, and B, it rises with the least degree of elevation. So one would assume that myoglobin is the answer. But if you compare myoglobin and troponin I is a more sensitive and specific marker of acute myocardial infarction as compared to myoglobin. So it would be most appropriate to request for troponin I, because remember, that's cardiac specific. It's only found on the heart. The next question is on chronic kidney disease. And basically the biochemical findings you'd expect to find in a patient with chronic kidney disease. Sorry, I'm seeing a question, the answer for the previous one. By previous one, I hope you mean the one for cardiac biomarkers.
Yes.
Yeah, troponin I. Okay. Biochemical findings in chronic kidney disease include the following: hypercalcemia, metabolic alkalosis, hyperuricemia, hypomagnesemia, or hypophosphatemia. Does anyone want to unmute and say whether the answer selected here is right or whether it's wrong? Okay. Bearing in mind that chronic kidney disease is long-term and most likely irreversible, Its biochemical findings would include, marked answer is wrong. What do you think the right answer is? Hyperuricemia. Yeah, that's right. Thank you, everyone who's answered. Yeah, that's accurate. In chronic kidney disease, there's hyperuricemia, and not only is urea increased, so is creatinine, phosphate, magnesium, and potassium. So this choice that suggests that there'd be hypomagnesemia and hypophosphatemia is automatically ruled out because we see there's an increase. And choice A, hypercalcemia, is wrong. There'll actually be reduced level of calcium, and there'll also be reduced sodium, reduced chloride, reduced bicarbonate, and erythropoietin. B is also ruled out because there won't be metabolic alkalosis, there'll be metabolic acidosis. And also, if you do the urine dipstick test, you'll find that there's albumin in the urine. So proteinuria will also be a finding. Okay. The next question takes us back to cardiac biomarkers and specifically creatine kinase. So which of the following statements is correct about creatine kinase? Can the metabolic acidosis be due to hyperkalemia? You guys, what do you think? Could it be due to hyperkalemia? You can chat maybe yes or no. So at least a majority should answer, because if you're not sure, you can just type maybe. Someone says could be due to decreased phosphate. Someone else says reduced bicarbonate. And someone else says, I think it is due to decreased reabsorption of bicarbonate. Thank you, everyone who's responded. I fall in the maybe group. I don't know. So which of the following statements is correct about creatine kinase? That it's a tetramer with 8 isoenzyme types, that creatine kinase is only contains the MB, that cardiac muscle only contains the MB isoenzyme. Skeletal muscle tissue mainly contains the BB isoenzyme. Skeletal muscle and brain tissues contain the same isoenzyme, or that the main circulating isoenzyme is derived from skeletal muscle. Omar says B. I hope in response to this question that cardiac muscle only contains the MB isoenzyme. Does anyone else have anything to say? There's a different opinion that the answer is the main circulating isoenzyme is derived from skeletal muscle. So that would mean that cardiac muscle contains 2 isoenzymes, maybe. Okay. Again, thank you to everyone who's responded. So creatine kinase has 3 isoenzymes. It has the CKBB, CKMB, and CKMM. BB, can remember brain, bladder. So brain generally means the CNS. So it's found in the brain, bladder, colon, and stomach. CKMB, on the other hand, is found in cardiac muscle, and CKMM is found in skeletal muscle and the heart. So bearing this in mind, if we go back and we eliminate choice A because creatine kinase has 3 isoenzymes, not 8. We will also eliminate B because cardiac muscle also contains the MM isoenzyme. You can see here MB and MM. Sorry for that interruption. We eliminate choice C because skeletal muscle doesn't contain the BB isoenzyme. It contains the MM isoenzyme. Choice D says that skeletal muscle and brain tissues contain the same isoenzyme, but that would be incorrect because skeletal muscle contains the MM isoenzyme and brain tissue, BB. So the correct answer is choice E. The next question asks, secondary adrenal cortical insufficiency is characterized by which hormonal profile? Okay, so there are different types of adrenal cortical insufficiency. N says E. Thank you. There's primary, secondary, and tertiary. Secondary happens at the level of the pituitary gland, the anterior pituitary gland to be specific. And so it's characterized by low cortisol, low ACTH. Choice E is correct because remember the pituitary gland releases this ACTH. Oh, I should also add that the primary adrenal cortical insufficiency is caused by the adrenal gland, and there'll be low cortisol, but normal ACTH. And the tertiary adrenal cortical insufficiency happens at the level of the hypothalamus. Tertiary is at the level of the hypothalamus. Okay, so for the primary insufficiency, it happens at the adrenal gland. Hold on, let me share another tab. Here, the primary cortical insufficiency happens at the level of the adrenal gland, the secondary at the level of the pituitary, and tertiary hypothalamus. Do you guys remember the HPA axis? The hypothalamus, pituitary, adrenal, when it's descending. So it's basically the opposite for that now, where the primary, since cortisol is produced by the adrenal gland, that's where the insufficiency is, and there's low cortisol. I hope it makes sense and that it's easier to remember now. Factors associated with paraneoplastic hypercalcemia of malignancy, except what are the factors associated with this malignancy? Parathyroid hormone-related protein would be correct. TNF-alpha would be correct. Interleukin-1 would be correct. And transforming growth factor alpha would be correct. Fibroblast growth factor is mostly in bone tumors. But interleukin-1 is associated with paraneoplastic hypercalcemia of malignancy. The next question is on secondary hyperlipidemia. Secondary hyperlipidemia may be associated with the following except. So what are some of the causes of secondary hyperlipidemia? And what's the difference between primary hyperlipidemia and secondary hyperlipidemia? Primary hyperlipidemia is inherited, but secondary hyperlipidemia is mostly due to lifestyle diseases lifestyle or acquired diseases. So of the options here, which is not associated with secondary hyperlipidemia? You can text your answer or unmute. C. Yes, that is correct. Acute kidney injury is not associated with secondary hyperlipidemia. It's chronic kidney injury that is associated with secondary hyperlipidemia. Remember that when you have chronic kidney injury, you have decreased insulin resistance, sorry. So that's why it would be a cause of secondary hyperlipidemia. All the rest are associated with it. The next question is on blood glucose. Interpret the OGTT. Fasting glucose level is 6.3 millimoles per liter. 2 hours after glucose ingestion, it's 15.7 millimoles per liter in plasma. So what could be happening? First of all, what type of test is an OGTT test? Like, what do these letters stand for? Impairment of carbohydrate tolerance. Oral glucose tolerance test. Yes. Okay. So bearing in mind that for fasting blood glucose, the normal levels are 3.2 to 6.1. So already this is increased. And for 2 hours after glucose ingestion, which is the OGTT, the expected normal levels would be below 7.8. So this is increased as well. So what would be the situation here if there's someone who has impaired glucose tolerance on fasting glucose and diabetes mellitus on OGTT? Because the two need to line up in some way. I'd say that the answer is D. It's necessary to repeat the test. Considering that on fasting glucose level, this patient's level point towards impaired glucose tolerance, I'd expect the OGTT test to be somewhere between 7.8 to 11.1 millimoles per liter. For visualization, these are the reference ranges. Okay, this next question might be the last one because it's a long one. So the following LFT findings obtained for a 46-year-old man. Total bilirubin is increased. Direct bilirubin is increased. AST increased. ALT increased. GGT increased. Alkaline phosphatase increased. So even before moving on to the choices to help us know which of the following is not correct, we need to interpret these results in some way so that we can have an idea of what we're going to be looking for. So I guess I'd first ask, what are some of the things that would cause an increase in direct bilirubin? Can put it in the chat box or unmute. What are some of the causes of an increase in direct bilirubin? Gallbladder stones, yes. Because gallbladder stones can cause obstruction, yes. Obstruction of bile, that's also true. There are quite a few, so if you have any to add, please feel free. Biliary atresia in infants, yes. Pancreatic cancer, yeah. Hemolysis. Chronic hepatitis. Okay. So hemolysis was a suggested answer, but hemolysis actually causes an increase in indirect bilirubin. I think so. Yes, hemolysis increases unconjugated bilirubin, which is indirect bilirubin. Thanks to everyone who's responded. So some of the causes of direct hyperbilirubinemia include hepatocellular carcinoma, chronic hepatitis, biliary atresia in infants, pancreatic cancer, bile obstruction, gallbladder stones, and the ones not mentioned here are alcoholic liver disease. And yeah, okay, that's all I have to add. So considering all that, now to narrow it down to what the diagnosis could be, the interpretation of the AST-ALT ratio is important. So if you do the ratio of AST, 2815 divided by 1330, basically, the answer is over 2. It's something over 2. 2 point something something. So basically, the ratio is higher than 2. And that points towards alcoholic liver disease. An AST-ALT ratio of less than 2 points towards viral hepatitis. Obstruction, on the other hand, like the gallbladder stones and bile obstruction, they only have a mild increase. The increase is not as higher up on the upper reference limit as these findings here. Okay. GGT finding was increased and alkaline phosphatase was also increased. These last two, GGT and ALP, they mostly point towards obstruction and biliary injury, while AST and ALT point towards cellular destruction of the hepatocytes. So if you're wondering why the AST-ALT would be higher than 2 in alcoholics, but not in people with viral hepatitis, remember alcohol damages the mitochondria, and AST is found in the mitochondria. So when the cells are being damaged, a lot of it is being released. And that's why the number here is so high that the ratio is a value higher than 2. High GGT finding, apart from alcoholic liver disease, can also be found in obesity and hepatocellular carcinoma. Okay. So which of the following is not correct? The patient will have pale stools. Patient is likely to have hypoalbuminemia. Serology for hepatitis B and C viruses should be done. The patient has a mixed bilirubinemia and hepatorenal syndrome may be a complication. Let me zoom out a little bit so you can see the choices plus the question. Someone says choice C, serology for hepatitis B and C viruses should be done. Someone else says A, the patient will have pale stools. Anyone else? Choice choice D and E. Okay. Hold on. Here are the choices. Choice D says the patient has a mixed bilirubinemia, and choice E says hepatorenal syndrome may be a complication. Okay, this is the only magnification where you can see both the question and the answers and the choices. But I don't know if everyone else can be able to see because it's quite small. But I agree with those who said choice C, that serology for hepatitis B and C should be done. A patient will have pale stools because CGGT and ALP are high. So if there's some sort of obstruction, bile is not leaving to get into the stool. So the patient will have pale stools. Okay, my time is up, but I think also this PDF will be sent, and I'll also send what I have here. Thank you so much. And I hope you guys have a good night.
Thank you, Angela.